Hi, Liane. I'm Marie. I'm the lead for the Maternity and Neonatal Voices Partnership in Shropshire, Telford and Wrekin. Nice to meet you.
Thank you.
On behalf of services, I'd just like to find out a little bit more about you and your role.
Yeah, certainly. My name's Liane. I'm the Maternity and Neonatal Independent Senior Advocate for NHS Shropshire, Telford and Wrekin. It's a new role. I'm a mum. I've got two grown-up children. I live in North West England, in Lancaster. Obviously spend our weeks working, but then spend the weekends away in our trusty old motorhome exploring the Lake District fells.
So can you just explain a little bit more about the role and what it means for the people of Shropshire, Telford and Wrekin?
Yeah, absolutely. So this role is a new role, and it's to support women, birthing people and families when they've been involved in, the official terminology is adverse outcome. So that basically means when something pretty dreadful has happened. So it might be that the mum or the birthing parent died, or the baby's died, or the mum's been really sick unexpectedly, or the baby's been really sick unexpectedly. And what happens when those kind of things happen in maternity and neonatal care is there's lots of investigations and meetings and lots of different bodies involved in trying to find out what went on. So not just the hospital, but external places as well. So coroner might be involved, or NHS resolution might be involved if baby's really sick, really poorly. And the role is to help support the woman, the birthing parent, the family through all that, because it's very complex and difficult and often really traumatic processes that people go through to try and find the answers that they need. Because we know from the evidence tells us that there's lots of what we call compounded harm happens afterwards. So it's not just the fact that it's awful, mum's been really poorly, or baby's died, or something of that nature happens. But when people have to go through really complex systems, it makes things a lot worse. And the role is to try and reduce that compounded harm. So it's to walk alongside a family and help them get the answer that they want. The MNISA role is, we're not there to give advice. We're not counsellors, we don't give guidance. We're there purely to speak on behalf of the family, to make sure that their voice is heard, and to use that experience to make things better in the future. Because when things go wrong, we can't make that better for that individual family. But what we can hopefully do is make things better for the next families coming along. So it's to use all that experience to make things better, but also to support that family, to make sure that things don't feel any worse in a very, very difficult, traumatic time.
So can you tell me a little bit about why the role was created?
It came out of the review into maternity service at the Shrewsbury and Telford hospitals, the Donna Ockenden review. And one of her many recommendations was that trusts need to listen to women and families, and she supported the creation of this role, basically this independent senior advocate role, somebody that was independent from the trust, so sitting within the integrated care board, so not part of the hospital, with no kind of ties to the area, to be able to support women and families who've been involved in one of those adverse outcomes. So that's where the role came from.
Does it sound too similar to my role in that I'm independent of the trust as well? So I'm leading the Maternity and Neonatal Voices Partnership, also known as MVP, which is an independent group that involves service users feeding back to the hospitals about their maternity and neonatal experiences. And whether that experience has been great or not so great, we want to hear it all. And that's used to help improve the services. There might be improvement projects that develop as a result of that feedback as well. So your role would sit really nicely with the work that I'm doing, so it'd be great to work with you in the future. And basically hear the voices of services and see what we can do to improve things.
So we can, my service can take, anybody can refer into me, so you can let me know of women or families that would like to talk to me, that find out more information, or women and families and partners can find me on the website and can self-refer via the website, or similarly teams that are supporting the women. So it might be a team at the hospital, the bereavement midwives, the governance teams. It might be people that don't work at the hospital, so the perinatal mental health services can refer to me. So I can take, anybody can refer to me at any point as well. It doesn't need to be just as something's happened, it can be kind of down the line, because what we do know is that there's an awful lot going on at the time when something like that happens, and it's very overwhelming and very traumatic, and often people just don't have space or time to be able to think, right, that might be useful. So I can become involved at any point down the line, as long as there's something unresolved about what's happened. So it might be that there's a coroner's case that hasn't gone to court yet, or it might be that there's something outstanding, there's a report outstanding or an investigation outstanding. I can lend support at any point along that timeline to try and make things better.
That's really helpful to know that it's so easy to refer on to.
Yeah.
Can you tell me what experience did you bring to the role?
Yeah, so I'm a midwife. I have been a midwife since 2000. I was a nurse for that. I did my midwifery training in London and worked there for a number of years in different settings, in a team midwifery setting. Moved up north. I'm from the north of England when I had my family, and worked at Morecambe Bay, initially at the Royal Lancaster Infirmary, but then got my job at the standalone midwifery-led unit at Kendal. So I worked there for a number of years. Then maternity services at Morecambe Bay were reorganised, so I took a couple of different roles on. They were kind of management roles across the trust. From there, I moved into a kind of a national to strategic kind of midwifery role, worked for Public Health England. Latterly, NHS England as an education manager in the NHS screening programmes. So I was helping kind of midwives talk to women about screening for certain conditions. Then I took as a comment just for 7 months in the Midlands perinatal team as the regional continuity care lead midwife, and that was about working kind of strategically across the whole region, supporting the 20 plus maternity units across the region, implementing midwifery continuity of care. So that was about giving strategic support to the leads in the different hospitals about what they needed to do to set up midwifery continuity of care. So again, not a clinical role, but a strategic role. I also work currently for the Nursing and Midwifery Council, so I sit on the fitness to practice panel, and that's an independent role. That's about assessing the evidence and making sure that we make decisions based on the evidence. And then I found myself here. So in my clinical midwifery roles, a lot of them had an eye on making services better for women and birthing people and families. So I set up vaginal birth after caesarean service. And on the back of that, it became really clear to me that the women I was seeing and talking to really needed a debrief service, and we didn't have one at the time. So then I set up a birth after thought service, and that was led by a group of midwives who would actually, women would seek our support. We'd go out to see the women at home. We'd go through the notes with them and talked about kind of what happened last time, what they wanted this time, what they wanted to know. So, this role brings all that together for me, because it's about supporting the women, the birth people and families kind of get the answers that they need, and kind of walking alongside them while they're doing that.
That really shows a lot of varied experience. That really shows that you put the person at the centre of the care that you're given. And you've mentioned a lot about being independent in a lot of your roles as well, and advocating. So can you tell me what makes this role independent?
So the role is, it sits in the Integrated Care Board. I'm not part of the hospital trust. I've no kind of professional ties to the area. As I said, I live over 100 miles away. So I don't have any kind of personal relationships with anybody at the organisation, at the local hospital, and nor will I build those relationships, because first and foremost, my loyalty is with the families and with the women. Of course, I need to have a working relationship, because I need to be able to attend meetings on behalf of the families, or if they want me to go to meetings, or, help them work through certain reports. So those relationships do absolutely need to be in place, but it is very much a professional working relationship, because my loyalty is with the families.
It's really good to hear. You can really feel that compassion coming through.
Oh, good.
So then, can you tell me when families can come to you for support?
It's up to the individual families. It might be as soon as something's happened. It might be much later. It'll be completely up to the families when they want to access that support. There's no time frames in terms of when I can and when I can't offer support. If there's something they need support with, there's something kind of ongoing, there's part of the investigation they need support with, or there's a letter that they want help writing, I can absolutely help with that. So it doesn't really matter. There's no rules around that. And I'm completely flexible because it will depend very much on individual circumstances and what's happened and how much information people want and need as to how long I support them for. So it'll be completely based on individual need.
I'm sure families will appreciate that flexibility. So if families felt they wanted to contact the MNISA service, how do they get in touch with you?
There's lots of different ways. I've tried to create lots of ways for people to get in touch, lots of different people to get in touch with. Anybody can refer to me. So it might be the woman or birthing parent themselves that want to refer to me. It might be the partner, it might be the family, it might be health professionals that are looking after that woman and family. So the GP, the health visitor, yourself, an MVP. It might be the neonatal support worker at the hospice, the bereavement midwife. It could be anybody that's involved in any aspect of looking after the woman and family afterwards. And there's lots of different ways. So I've got a phone number, I've got an email. On my website, there's an embedded kind of contact form in there that people can fill in, and they can also let me know on there if they need. It can be translated, and if they need help in information in different languages, that can be on there. So it's not a really complicated referral form. It's what I call the contact form. So it really is just name, phone number, a little bit briefly about what happened if you want to tell me, but it doesn't matter if you don't want to go into that information. And I'll get straight back to them in 7 working days. I don't want people to worry about whether or not to get in touch, even though there's a referral criteria. People aren't sure. Just get in touch. We can talk about your situation, tell me a little bit about what's happened, and if it doesn't fit with the kind of referral criteria of the role, I can certainly help direct you to the places that are going to be best suited to help you.
Thanks, that's really helpful. So it's been really great talking today, Liane, and finding out about the MNISA service. So I just want to thank you on behalf of our service users and all families of Shropshire, Telford and Wrekin.
Yeah, thanks so much. It's been great to chat to you and explain a little bit more about the role.